a global public health problem. It's an ever increasing incidence and prevalence, what we are saying. And the most important is really having a big influence on the healthcare expenditure and with a poor outcome rather. So that's very important. And it is also associated with the increased risk of cardiovascular disease and end-stage renal disease. So it becomes very, very, very important, particularly for us being a diabetologist. It has become a very important part and parcel of our patients. So how do we really define it? It is defined as the presence of an abnormality in kidney structure or function persisting for more than 3 months. You can always define it, and thereafter you have to understand where are the culprits. Culprits obviously is glomerular hyperfiltration, hypertension, and nephron loss. So once you define it, then you have to actually stage it. So that's very important. So you need to first and foremost test for the CKD. In order to define it, you have the serum filtration markers. You have the kidney damage markers already excellently dealt with my previous two speakers. And along with that, you have a certain range, which is important, a criteria for CKD diagnosis. The presence of one of 4 markers is also important while defining CKD. It could either be urine sediment abnormality, it could be histological abnormality, it could be structural abnormality, or it could be a history of kidney transplant. So any patient who has eGFR of less than 60 or ACR of more than 30 for more than 3 months, these can be defined as CKD, and we need to understand or determine the cause with clinical history, physical examination, and the parameters which already we discussed about. So as already spoken about, you need to understand, or you have to really define the category either by eGFR or by the albumin criteria. What is more important, and because I'm not going to deal in details, what is more important is what are the changes which have occurred, and what are the important information which we need to carry with us. So if you go through these various studies which have has been undertaken, and more importantly, particularly in elderly, where there could be basically a muscle loss, there could be alteration in the creatinine level, and that may not be a great way to define CKD. So if you can combine the cystanin with the creatinine, probably that will give a better way to assess the renal function in elderly. And already the urine omnics has been described. Those are the recent ones which can be thought about. But what most important is, if you really combine these two parameters, probably you'll be in a better shape to assess the renal function elderly. So what is the prevalence as far as India is concerned? This is quite variable because we have different studies from different parts of India. But overall, what the International Society of Nephrology Kidney Disease data center said, it is about 17%, but in India, it could be a variable right from 1 to 30%. In certain population, it is much more than that. But we are concerned about one population, that is type 2 diabetes, and we are already in such a pandemic. I'm not talking about COVID pandemic, probably we are in a diabetic pandemic. And we have a huge population, a global population of 422 million diabetics. And out of that, 30 to 40% expected to have diabetic kidney disease. As has broadly been described, what is diabetic kidney disease by my previous speaker. And what is more important is the prevalence rate of DKD is about 3%, expected to grow annually. And that is of great concern. But in spite of knowing the fact that the prevalence rate is so high, 38% receive no or little pre-end-stage renal disease nephrologic care. That's very important. So this is a huge population where probably they are not even managed well. So that's important. So the demand study was shown in one of the graphs by my previous speaker, which actually assessed about 32,000 patients across 33 countries, and they said that 50% of the population with diabetes had CKD. And this is basically, I think it's a globally present, and that's what is seen in the population as well. So we are probably dealing with more than 100 billion populations. What is the changing presentation? Has already been dealt a little bit, but then although we had this hierarchy, we had a normal urine thereafter going to micro, macro, clinical proteinuria, and stage renal disease. Now that's not the concept in the current view. We can have straight away a normal urine albumin and presenting with end-stage renal disease. And now with such a good molecules coming in, probably we have a chance or reversal, right, from clinical proteinuria to normal urine albumin as well. So this is the changing presentation which we see in our kidney population. So there have been many trials which actually failed to demonstrate the benefits in data, particularly in diabetic kidney disease. These are the various trials. You can see the various molecules have been used, and unfortunately, most of them has failed to demonstrate any benefit in DKD. What about the KDIGO 2021? It clearly says target the BP in patients with CKD. And that's very important, that you need to have a standardized and the measurement of blood pressure in a proper way. So it should be like you have to have a blood pressure measurement for adults with chronic kidney disease and those who are not receiving dialysis. So basically, these are the clinical practice guidelines. Along with that, advice is given that the targeted systolic blood pressure should be less than 120. How do we really slow the CKD progression? The CKD progression, we vary about the ACE or the ARB, and we can continue with these drugs if less than 25% serum creatinine is there with initiation of these drugs. But if more than there is, then you need to reevaluate the issues and might we have to evaluate the renal artery stenosis. But there is no absolutely EGFR cutoff for contraindication for initiation of ACE or ARB. Along with these two molecules, the better proteinuria suppression with low sodium diet and diuretics and avoiding the volume depletion with other measures which can slow the CKD progression. More importantly, you need not combine the AC and ARB. You should not combine all that. And obviously keep an eye on the adverse effects. And the most common being hyperkalemia, and how it is dealt is already been spoken about in the first lecture. And this is what is very important. You need to address the issue of hyperkalemia, very well spoken by my previous speakers, so I'm not going into that. And drug dosing consideration is of vital importance in CKD, whether it is anti-glycemic agent or any other agent. You need to understand, and you need to modify your dosing or the dosage so that we do not cause any ill effect on not only on the patient, but on the organ itself. So how do we diagnose DKD? If you obviously the CKD diagnosis need to be made, then by EGFR or by albumin level, a spot sample can be taken because that's very simpler to take. Obviously, there were pitfalls which Dr. Hertzforden has enumerated very well, but that's very important. I need to understand when you need to screen for DKD in type 1 and type 2 population. But what is more important, which probably has been already spoken about, that a substantial percentage of DKD is now non-proteinuric. So up to the tune of 48, and all these studies have clearly shown that a great population or the good amount of population of DKD might be non-proteinuric. So this becomes a big issue. How do we really classify this CKD to be a DKD? Then you might have to consider a kidney biopsy as well. And these are the various reasons or the important factors which will determine that the atypical presentation could be the reason where you have to plan out for a kidney biopsy. Whether it's absence of retinopathy, it's no more a universal truth that a presence of retinopathy is necessary for a patient to have a DKD. Albuminuria developing less than 5 years or more than 25 years, on the onset of disease, immunological markers or active urinary sediment, acute or sudden onset macroalbuminuria or nephrotic syndrome, hematuria, rapid decline in renal function, significant reduction in GFR after initiation of RAS, and acute kidney injury. These are the various factors which will actually help, where we have to make our mind that whether we should consider this patient to be a DKD or whether we need to have a kidney biopsy to establish it. But one thing is for sure, that the coexistence of the kidney disease and diabetes is associated with the greater mortality than the sum of the excess risk associated with either diabetes or kidney disease alone. And you can make out from this particular graph that the 10-year mortality, right from when you have no kidney disease, is about 4%. But as the progression of the kidney disease increases, as there is a progression from albuminuria to both albuminuria impaired GFR, it goes up to 47%. So basically, when you have both diabetes and kidney disease, that can have an important predictor for increased mortality in patients with diabetes. And this is what we were saying, and this what we are seeing right now, is that diabetic CKD plus cardiovascular disease will both together will be having increased incidence of hospitalization and increased death. You can see the green bars, whether at a level of kidney disease, if you have a combination of DM and CKD, it will have an increased incidence of death along with the increased incidence of hospitalizations. So obviously these two together leads to a huge burden of mortality in diabetic population in particular. So what are the treatment guidelines? For the first time, PDO 2020 came out with glycemic guidelines. And that is what, again, they have said it is the individualization of the therapy is important, or glycemic goal is important. If you have comorbid condition or have increased burden of hypoglycemia, a conservative approach can be undertaken. Whereas if you have a prevention aspect, which is the major criteria, then you should have a lower HbA1c target. And let's see what they have published. So basically, what they have suggested that in all patients, you need to have a proper lifestyle, and along with that, a good glycemic control, a good blood pressure control, and dyslipidemia need to be managed. Whenever you are considering a good glycemic control, what they have suggested that with type 2 diabetes and CKD, the first line treatment is and additional drug therapy as needed for glycemic control can be done with any of these agents. And how do they have come out with a similar kind of therapeutic wheel, which RSSD had come out. Now KDIGO has come out with this therapeutic wheel, and probably you will appreciate that several patient factors are taken into consideration while planning out any therapy over and above SGLT2 and metformin, over and above, whether it is you want a potent glucose lowering factor, or if the patient is high risk atherosclerotic CVD, or fluid overload is a major concern, or if the eGFR is very less, or you have to involve the financial aspect of that individual. Weight loss is a factor, or you just have to keep on oral medication. And last but not the least is avoiding hypoglycemia. So these are various patient factors which need to be taken into consideration to manage the glycemia. But the primary KDIGO guideline says the primary molecule which should be initiated when you have diabetes with DKD is SGLT2 and metformin. And this is what the ADA 2021 has said, as well as far as glucose lowering medication is concerned. If the patient has CKD, the preferable drug happens to be SGLT2. So where does SGLT2 stand today? Because this is what we are basically focusing on, even all the diabetologists, all the cardiologists, and now the nephrologists. It happens to be the drug of nephrologists now. So these SGLT2 inhibitors, they decrease not only the glycated hemoglobin level, but they have shown favorable effects on the kidney and cardiovascular outcome in almost all the trials. And if you go through majority of the trials, so meta-analysis across the clinical trials has shown a substantial reduction in end-stage kidney disease, loss of eGFR, renal death, reduction in renal death is also observed. So whether you take Emparec, whether you take Canvas, whether you take declared TB or associated with SPIDANS or any other clinical trials, they all have in their subgroup analysis or the exploratory analysis have shown a definite reduction as far as the kidney outcome is concerned. So they all are renal protective. The whole SGLT group looks like a renal protective agent. So this is the departure, or this is the basically advancement as far as management of CKD is concerned. And this is what we are going to look into. So SGL2, what this happens to be the game changer, because all the recent published data has highlighted the benefit of SGLT inhibitors like dapagliflozin in heart failure and CKD, irrespective of diabetic status. If it had only been the diabetes, then obviously you could have streamlined that it is basically for diabetic kidney disease. But irrespective of the diabetes status, they have shown the protective effect, and that has emerged as a game changer. So the renal effects, if you look for these two particular molecules which you use in CKD, whether it's ACARB or the SGL2, both of them through the different mechanism, one through the afferent arteriole, the other to the efferent arteriole, ultimately reduce albuminuria and causes immune protection. So both of them together have a kind of a synergistic effect in given CKD. And everyone is aware of the mechanism of action, the dapagliflozin. Obviously, it inhibits the SGL2 in the proximal tubule, thereby reduce the glucose reabsorption and increase glucose excretion. That's how the glycemic effect takes place. And you will appreciate that the clinical trials of SGL2 have undertaken across the cardiorenal continuum. So if you see, wherever there were risk factors, these two studies, declared TB and Canvas, played its role. When you have the established atherosclerotic CVD, you have the Vertis CV and Emparec outcome, which had the which was undertaken in this group of population. And when you have the heart failure population, you have the Emperor reduce and DAPA-HF. And there were exclusive kidney outcome studies. There were Credence and DAPA-CKD. The difference between the two studies, I'm going to tell you in the next few slides, but definitely see along the whole cardiorenal continuum, the SGL2 has been studied. And that gives us an extra benefit of understanding this particular molecule as far as the renal protective effect is concerned. So DAPA-CKD was stopped because of clear-cut efficacy, which shown much before its date of stoppage. Sorry. And what it showed that the primary composite endpoint, there was a huge reduction of 39%. But if you go to the renal specific composite outcome, the reduction was much more, to the tune of 44%. That is sustained decline in EGFR, end-stage renal disease, or death from renal cause. So a clear-cut winner as far as the renal trials are concerned. And if you look at the composite of death from the cardiovascular causes and hospitalization for heart failure, there was 29% reduction, or death from any cause, it was 31%. Along with that, what we see, this was the additional endpoint where we found a 34% reduction with chronic dialysis, kidney transplantation, and renal death. So overall, DAPA-CKD study, a CKD trial has given us has shown us a light around the tunnel where we can use this particular molecule in kind of for renal protection. And this was the analysis which was presented at the American College of Nephrology in October 2020, where it clearly said reduction in the primary composite endpoint was consistent regardless of the kidney disease etiology. Whether any etiology, it showed a consistent composite, primary composite endpoint reduction. Along with that, it also said that reduction in CV death or hospitalization heart failure was across kidney disease etiologies. Proportion of the patients who discontinued dapagliflozin due to adverse events or experienced serious adverse events were similar across kidney disease etiology. So not a single etiology, whether you pick up nephropathy, whether you pick up glomerulonephritis, ischemic hypertension, CKD, or CKD of unknown origin. Even in patients with CKD, dapagliflozin reduced the risk of kidney failure, death from cardiovascular causes of hospitalization heart failure, and all-cause mortality, regardless of underlying etiology. And if you really analyze even the empiric outcome study, it also had similar kind of analytical data which showed some benefit as far as kidney data is concerned. And we are expecting the similar kind of data from the EMPA kidney outcome as well. And this was a new DAPA CKD analysis where for IgA nephropathy here, it showed about 70% relative risk reduction in the rate of end-stage renal disease. So even in the IgA nephropathy, this particular molecule has some positive impact. And this is where the difference between SPIDANS and DAPA CKD was seen. DAPA CKD had population which was non-diabetic as well, about 32% of population. SPIDANS didn't have any non-diabetic population. And the only other difference probably was in the all-cause mortality, which was much higher, which was the reduction was much more in DAPA CKD vis-a-vis the PIDANS. So basically, whether it is a diabetic population or a non-diabetic population, this SGLT2 seems to be scoring heavily as far as protection is concerned. So basically, this is the drastic change or shift in the management of CKD, which we are anticipating. So as far as safety is concerned, obviously, the DAPA CKD has clearly shown that most of the adverse or safety outcome data, which was there with the initial studies of CVOTs, they were not of major concern when DAPA CKD study came out. And if you see the Emperor reduce and DAPA HF, the heart failure trials, which the SGLT2 inhibitors undergone with dapagliflozin and dapagliflozin heart failure, reduced ejection fraction, there even it showed a reduction in the kidney composite up to the tune of 38%. So basically, in patients of heart failure also, there is a reduction in the kidney composite outcome and a good 38%. So basically, this all led to the impact which actually had on the various authorities. The dapagliflozin was granted the breakthrough therapy designation in US for chronic kidney disease. So it became a molecule for CKD, not only for DKD, but CKD. And the similar, our drug controller gave it's not for patients with CKD. So it's no more a molecule for diabetologist, which is a non-endocrinologist. It's a molecule for cardiologist as well as for nephrologist. So Dr. Hertzbergen will be, I think, will be very happy to use this particular molecule for his own patients as well. And these are the proposed renal protective pathways which the SGLT2 probably has. That is, there is an increased oxygenation of tubular cells based on decreased demand for solid transport and increased hematocrit leading to the increased oxygen delivery. There is a decrease in the intraglobullar pressure due to the tubular glomerular feedback effects. There is a decreased albuminuria, reducing possibly direct toxic effects on renal tubules. There is a loop diuretic sparing effects. There's a preservation of the intravascular volume and reduced volume overload. That's important as well. And obviously, we have those cardiovascular effects where there's a direct cardiovascular effect when it improves the cardiac function with maintenance of the renal perfusion. Improved metabolic parameters, we all know about it. The glycemic status is taken care of. There is a weight loss, and there is a reduction in the pro-inflammatory and pro-fibrotic pathway as well. Probably the DARE study, which has come out in COVID times, probably that is pointing towards that. There is a decrease in the blood pressure, even in the presence of CKD, decrease in the endothelial dysfunctions, and decrease in arterial stiffness. Overall, all these factors can have a positive effects of cardiovascular disease and the renal disease is concerned. So the other factor obviously will be treatment of diabetes and dialysis, and I can vouch for insulin only, and only one oral hypoglycemic agent, that's DPP4, and particularly linagliptin is the one molecule which can be used, or the other DPP4 with reduced doses can be used. But most important is to prevent hypoglycemia. Insulin may have to be reduced by 50% when the eGFR is less than 10, or you need to lower the basal insulin by 25% on the day after dialysis to prevent hypoglycemia. These two are important factors when the patient is on dialysis. So overall, whatever we said, as a diabetologist, we are able to not only make a diagnosis of CKD, we are supposed to give maximum protection with whatever molecules we have. Now we have anti-glycemic molecules which will be having a protective effect of kidney, but still there is a role of nephrologist, and this is where it's very important. A timely referral to the specialist kidney care services is important. And these are the various markers or parameters where you should make this decision to refer the patient to a kidney specialist, whether it is a acute kidney injury, a GFR less than 30, persistent albuminuria, typical progression, mature refractory hypertension, persistent abnormality of potassium, recurrent or extensive nephrolithiasis, or hereditary kidney disease. So friends, it's very important that we obviously have the molecule, a wonder molecule now, but in spite of that, a timely referral to a nephrologist is very important in these certain criteria of clinical conditions. So to summarize, I would say diabetic kidney disease is a chronic inevitable outcome in type 2 diabetes. The current therapies have certain limitations. The new therapy, particularly SGLT2, has shown exceptional therapy options. In the days to come, we might be seeing a change in the horizon of the management of CKD. Obviously, ACI, ARB, ALDO antagonists need to be considered, and where required, complications of CKD need to be treated, and treated CKD overall, whether it's anemia, etc., they need to be taken care of as well. And obviously, you need to consult the referring physicians about the efficacies of or the safety of anti-glycemic therapy. Thank you. Thank you, sir.
Thank you very much, Dr.
I hope I finished in time.
You have done a wonderful job. So you have done wonderful job. Since we have time limitation, so can we take one question?
I promised 15
or
minutes, so I think I completed in 15 minutes, right?
Actually, there is one question in the chat box.
I make a comment.
Dr. Birmani sir, Dr. Birmani sir.
Yeah. One question.
Yeah.
Okay,
Dr. Vardhan wants to come in. Yeah.
There is one question in the chat box also. The question is for all the speakers: as age advances, should reference age of serum creatinine should be changed? As in some old patients, serum creatinine is around 1.5. Should it be investigated further? This is a question.
Dr. Ashwardhan, please answer. Do you think serum creatinine, the levels of serum creatinine should be adjusted with age? That's the question. Should age be a criteria?
This is a very pertinent. Am I audible?
Yeah.
Please go ahead.
This is a very pertinent question, and we nephrologists have always looked into this data, and probably we have few papers which has looked into this matter. To be very frank with you, till we find a better marker, creatinine with all its limitation still, somehow holding on. We need to look at it differently. That is for sure. Number one, because the moment, there is a practical decline in GFR as the age starts more than 30 years. So we really need to look at this thing, creatinine as a marker of kidney disease, and what should be the value. Because what is happening, as soon as the age increases, the eGFR automatically calculates your GFR less than 60. So it is always important that whenever you diagnose somebody with chronic kidney disease, it is not the GFR value, it is implication on health. That has to be taken into consideration whenever you say that he or she is having chronic kidney disease.
Okay, thank you. I think we'll move on to the next session.
Can I make a comment?
Yeah.
Well, I heard these speakers, and it was really an excellent talk. One comment I would like to say is that there is a collateral effect of SGLT2, and we all should look, and that is correction of hyponatremia.
Please mute. Yes, go ahead.
A very important effect of SGLT2 inhibition is correction